Pradeep Ramulu took the train up this morning from Baltimore to join us from Johns Hopkins, where he's professor and chief of glaucoma. Looking forward to the lecture, Pradeep.
Thank you, Bob, and thanks to all of you in the audience. So I'm going to talk to you about lifestyle and kind of take a little bit of a philosophical approach and about how much we really need to dive into this with our patients. And if so, what specifically do we say? These are my disclosures that won't come in right that too much over here in this talk. So this actually ties back nicely to Janie's talk this morning, which is if glaucoma is so genetic, do we even need to be talking about this? You know, is it already all programmed for people? So it's like, well, why even manage this, right? You know, if it's a genetic disease and the pressure is the addressable factor, then, you know, just forget it. Let them do whatever they want to, right? And this is not said so extremely, but said in a milder version by a recent review by Jamie Craig, where he makes the point that Janie made, that this is the third most heritable disease. And that kind of is keeping in with the fact that there's no known environmental factors that are clearly associated with glaucoma. So so I kind of start out with this more kind of, you know, generic or, you know, large question over here. Well, this is the way I see it, and I think Janie had visited us once to give a lecture and to do a journal club, and so we kind of discussed this concept over there, which I think she agreed with, which is that, you know, I think most people have a genetic set point for, you know, if and when glaucoma is likely going to set in. But if you had 100 people with that same exact genetic risk, you know, how would their likelihood vary? And it's probably not going to be exactly the same. You know, some people are going to get it earlier, some people are going to get it later. There's going to be some difference. I mean, they're going to be similar, but they're not going to be exactly the same. And what does this variability come from? Well, presumably this variability comes from, you know, epigenetics, and, you know, this epigenetics comes from our behaviors and what we eat and you know, lots of other things, our stress levels. And so, you know, so if this is your expected age-adjusted risk for the level of genetic disease, and this is kind of, you know, what you would see in a bunch of people, you know, the question really becomes, well, if that's what it is, it's like, well, is that all that there is, or is it actually that you could actually do better? So in other words, are there kind of these super outliers or these behaviors that could produce, you know, a big outlier from this line, so which can kind of greatly lower the risk, and you don't actually see it in the population because nobody's doing it, you know, so, you know, nobody's actually doing that. So it doesn't actually manifest in this variability because that's just not part of our behavioral pattern. This may be true. So this is one study that's really provocative. You know, it's retrospective, it's self-reported glaucoma, but the Williams study from 15 years ago found that, you know, they actually took men age 45 and they followed them for 8 years. And they found that the faster that they ran, the less likely they were to get glaucoma over this period of time. And then there were some men who at some point in their life were able to run a 10K in 33 minutes. That's fast, you know, that's 5.5 minutes a mile. And none of them got glaucoma. You know, I mean, you know, what was the expectation? Probably about 4 or 5. So it's not like a miraculous result, but it is, you know, somewhat telling. And the more they ran also, the less often they got glaucoma. You can say, well, what's up with this male runner study? You know, isn't that, you know, isn't this the kind of thing you're not allowed to do at the NIH these days, or just in general? Well, they couldn't actually even analyze the results in women because, like, nobody got glaucoma at all. So, you know, in the women, like, they were just basically, if they were a runner, they almost never got it. This is not the only study that's shown this. So there's a study from Iowa State University where they actually found that people who did this is again, you know, diagnosed by self-report, both in terms of their glaucoma, and but if you actually looked at like their self-reported physical activity, the people who said that they were more active didn't get glaucoma as often in this community study. They actually measured their fitness objectively, and the people who were in the middle and higher third of fitness actually were less likely to go on to self-report glaucoma than people who were in this lower tier. So maybe there is something. You know, this kind of like, you know, brings up an idea that, you know, when we've always been studying these, you know, behaviors and relating behavior to glaucoma and trying to understand whether these behaviors, you know, protect against glaucoma. But actually, I don't know that any of these studies were ever done as well as they should have been done. And if I had to start all over, I would do things differently. But if you have sets of people who had like these 3 levels of risk, you know, very high genetic risk, they're going to get the disease. The people who are kind of in between, so it may depend on, how long they live and how they live. They may or may not get it. And then there's the people who, they can do whatever they want and they're not going to get it. So this is the equivalent of the people who are eating a cheeseburger every day and, living to 95 with no evidence of heart disease, right? So, if you take these people who are at high risk, maybe you can slow things down a little bit, but it may not make that much of a difference. And then if you take these people who are in the middle, those are the areas where you probably are going to really make a difference in terms of your behavior, or at least potentially. And the people who are low genetic risk, I mean, there's no reason to advise these people to do anything differently because they're not going to get the disease anyway. So probably in the future, we need to be able to look at these, behavioral risk factors accounting for this, because you really want to look at it mainly in this middle group and see whether you can kind of change the outcome in that middle group. This is what Anthony Kawaja did for caffeine, where he found that there was no association with prevalence for glaucoma, except in people who had a higher risk of IOP elevation. He's used one of these polygenic risk scores that Jenny described earlier in her talk, although this was an IOP PRS. So in other words, the genes that predispose people to a high level of pressure. And what he found is that the odds of glaucoma increased if you if you drank more caffeine, or in the people who had a high predisposition to glaucoma, more caffeine was bad for them. But if you had like a low predisposition, it doesn't really seem to matter. So for most people, you can drink caffeine and you're just fine. If you're at a high risk, it doesn't, it probably is not a good idea to overdo it. He did a similar type of analysis with exercise. He did find that people who were more active seemed to have a slightly healthier OCT in terms of the ganglion cell and IPL thickness. But on the other hand, there were no associations of this that were modified by the glaucoma polygenic risk score. So in other words, their risk didn't modify that. So it kind of goes against what I said before, but this was one study from the UK Biobank. So, well, how do you judge whether some sort of lifestyle element is really important or not? I mean, I think the one that we often fall back upon, because it's just so hard to show that any of these things are useful, is does this lifestyle actually lead to any difference in IOP? And then you can start looking at other things that it's hard to know what to make of. Does it change the physiology of the eye? In animal studies, does it seem to be protective against the eye? Does it actually seem to have some associations in people? And we'll go through some of these for some of the different lifestyle elements that are shown over here. So let's talk about IOP. So, marijuana is one that I think everybody gets asked about all the time. It's one of, in addition to the ocular surface, that's, the question that we try and avoid every week, is to avoid answering. So, I think the simple answer, which hopefully all of you know, is that, it creates a very transient treatment. So, it really only lasts about 4 hours. I think that doesn't really convince everybody that they shouldn't do it anyway. There's lots of other reasons too. If you really get the patient who really wants to be engaged in this idea, the dosing is not standardized. If you just look at what people are going to get, it's anywhere, but THC is what actually lowers the eye pressure, and the active amount of that in various joints is going to be 2 to 20%. The dosing that you need to lower the IOP is the dosing that has both physiological changes, including lowering your blood pressure, and psychotropic effects. So in other words, you have to be high to get your pressure low. So it's not, it's not something which you can do and still be functional and going to work and doing other things and driving. Of course, there's hundreds of secondary compounds which may affect your glaucoma or other organs. And, now when people talk about marijuana, they talk about a whole bunch of different things. And CBD oil, for example, which is really popular, has no effect on IOP, although a lot of people want to use that as a substitute. So the other issue which has been brought up is that, a lot of the studies that I'm talking about, which I will talk about, are on people who are not on any treatment at all. But, this is a study that two of my colleagues, Tom Johnson and Henry Jampel, did, looking at how much extra IOP lowering you get from each additional medicine as judged by the washout portion of the HYDRIS clinical trials. And inferring from this, you see that you get about 6 millimeters of mercury from the first drop. You get like an extra, millimeter or two from the next 2 drops, and you basically get nothing for the 4th drop. So, it's really hard for anything, either an intervention or another drop to actually do anything once you're already on a whole bunch of medication. So if you're doing this as kind of a way to stave off surgery, good luck. I was pretty surprised by this result. So we were actually getting some pilot data looking at exercise and its relationship to physiologic changes in glaucoma. And we actually found that in patients we did this in individuals who were on treatment, and then we washed them out for a short period of time. So when they were washed out, we saw that just a single bout of just being on the exercise bike for 5 minutes, very, very simple, not a very high heart rate, lower the pressure by about 5 millimeters of mercury. On the other hand, even when they were on their treatment, it lowered it by about 3.5 millimeters of mercury. So these were actually treated patients. And we got a 3.5 millimeter mercury decrease with that. Whether that would be sustained with a consistent exercise program, that's something that'll be a grant in a year or two. This is not the first time that this has been found. These are data that go all the way back 30 years, where they took these sedentary ocular hypertensives and they started exercising them, and they found that their pressure went down. And then the nice thing is that they crossed them back to like their regular behavior. So, it's hard to continue these things, right? So, you exercise, then you stop exercising, and their pressure just went right exactly back to where it was in the first place. So it does work in lowering pressure, but you have to keep on doing it. This is the same work that I showed you earlier about, the risk of glaucoma was actually true for IOP elevation too, with regards to coffee and caffeine. So this is the work that Anthony did along with Janie and Lou to look at the interaction with the amount of caffeine you took and the degree of IOP lowering. And so I think what you see here again is that in people who have a high risk of an IOP rise, caffeine seems to increase their risk. And so this is a strong argument for starting to get in some of these PRS scores, especially if they can really kind of guide some specific lifestyle adjustments that we would want them to make. I think the work by Tanuj Datta on meditation has really been pretty incredible. So this is he did a series of these randomized trials. This one that I'll talk about, patients had an average damage of minus 14 decibels. He did not stop their IOP lowering meds, and he had them come in person for 21 days in a row to do a 60-minute session. The first 15 minutes of breathing and 45 minutes of mindfulness. It's just paying attention to the current moment is how he describes it. I don't know exactly what it is, but it sounds good. It sounds like something I'd like to do. And then the IOP measurements were not right afterwards. So they were like a few hours later. So he's not measuring what's happening like in the moment. And he saw this nice decrease. So, patients were treated, but they weren't like super treated. But, he sees a nice decrease in the IOP afterwards. And 75% of them showed an IOP drop of 25% or more. Well, what about physiology? And can we even really say anything? Do we know what physiology matters? I think that this is certainly a struggle for our field, is that we don't really know what is the physiological change that we can use as a meaningful surrogate to judge whether intervention really works. What's going to serve as a disease marker? If you take something such as blood flow, which other people in the audience know more about than I do, do you look at static measures, or do you have to look at it dynamically? Do you have to look at change across conditions? And if you look at changes across conditions, do you look at like light stimulation, IOP, physiology? And then what direction of change is problematic? Sometimes when there's misregulation, actually, you'll see more of an increase in some cases. And so is that problematic, or is like insufficient change problematic? And so I think the only way we're really going to know what physiologic changes really matter are after we've shown that some sort of behavioral intervention works. And then we can go back and look at what physiologic changes actually predicted the success in the first place. So there is a study that was done at Bascom Palmer where they did put just a normal set of older adults through a circuit training program. So where they actually did weights, and they increased their heart rate. And they did find that there was changes in tissue perfusion and retinal blood flow. And so you can change these parameters for whatever that means. There's strong evidence that you can improve mitochondrial function. That you can actually get increased mitochondrial number, and that you could also get more mitophagy and mitochondrial turnover. All this is in skeletal muscle. Inas joined us for a journal club last week, and I said, it'd be great to use some of the measures that she's using and try and link it with a activity measure and see whether you can actually see any of the things that she's measuring actually change in the retinal ganglion cells in terms of their mitochondrial number or function with regard to such an intervention. Tanuj showed that with regards to meditation, he saw a whole bunch of serum biomarkers change. I mean, it was almost like too good to be true, but except when you start looking at the literature and you see that every other meditation study showed the same thing. So in addition to lower IOP, you saw higher serum BDNF levels. You saw another higher antioxidant levels, lower cortisol, lower IL-6, lower TNF alpha, lower oxygen species, reactive oxygen species. So really a bunch of serum changes. To what extent do they actually manifest in the eye? I don't know, but they're certainly very provocative. He also showed in another publication that he saw higher OCT angiography measures as well. And so that there may actually be either vasodilation or actually maybe even more flow. Well, what about, is there anything that really suggests that this works, maybe in animals? And I think there is evidence that in animals, exercise really is protective. So this is work that Jonathan Craftston and Vicky Chrysostomo and from Australia have done, where they show that if you take mice and you subject them to a higher IOP, their ERG, which represents their ability to create a retinal signal in response to light, goes down. But if you actually exercise those mice, then you protect against that. So in this second black bar, you see that the bar is higher, so that mouse has been protected. And they actually show the specific pathway through which this works. So if you give the mouse a antagonist to the receptor for track B, then they actually start becoming damaged again. If you actually do this experiment in a mouse that is haploinsufficient for BDNF, which is the pathway that runs through track B as well, then again you don't get the protective effect. Humans release BDNF with exercise. So even with a single bout of exercise, you'll see BDNF in the serum go up. To what extent it goes up in the eye or the optic nerve, I don't know. This is one study which again seems almost too good to be true, where they looked at like the degree of damage in people and their BDNF levels, and they sounded like almost incredibly correlated, maybe almost like too correlated. But what about like actually, data in humans? And there is some data in humans that we found that people who are more physically active people who have more glaucoma damage are not as physically active. Of course, you don't know what is the chicken and what is the egg over here. We found that people who have worse vision also change how they do their physical activity. So, the worse your vision, the more you do your activity in smaller amounts. So in smaller little pegs. I don't know whether that's because you're afraid and so you try and kind of keep things small, or they're because you already have some mitochondrial dysfunction and so you can't tolerate longer sustained periods of exercise of activity, and that's why you're kind of breaking things down into a more fragmented activity pattern. This is one of our residents who just graduated and will be doing a glaucoma fellowship next year at Wills, and she looked at rates of disease change 5 years before and after a 1-week activity assessment, and she found that more active people did progress slower. But the effect was pretty mild. You had to take 5,000 extra steps a day to have a 10% slower rate of progression. But the effect did persist independent of age, race, disease severity, and IOP. The last thing I'm going to talk about is systemic health. I didn't put it on the list originally, but I think it's actually the most important one. Because you have to kind of consider what you're telling people and whether it really makes any sense for them. I think Jamie Craig is partially right that we don't have very, first-rate evidence for lifestyle changes. And so if you're going to tell somebody to do something, there ought to be some, maybe some secondary benefit behind it. I think obviously like exercise is something which is good for you. It is the poly pill, if you would. It's strongly associated with mortality, heart disease, cardiovascular disease, multiple types of cancer, mood, falls. And this is a study that actually looked at this population attributable risk and found that, some major things, heart disease, diabetes, breast cancer, colon cancer, mortality rates all go down with exercise. I mean, I think that the effect is probably pretty strong if you adjust it for age. I don't know how they dealt with age over here, but you got to die from something at some point. But, especially in that sweet spot when you can be healthy, I think exercise really, really helps you. This is a slide courtesy of Tanuj Datta, who is doing this work for the WGA, who actually found that in brains that were brains of individuals who were meditating, it actually seemed to protect against age-related atrophy, and there was some measure of brain age which was even better in the meditators. I don't know exactly what a younger brain looks like. And certainly for those who do some meditation, you do feel better. And I think there's increasing science behind that, and then in terms of reducing pain, reducing anxiety, improving blood flow and calm, and also helping against disease as well. So final thoughts are that, there's lots of factors to consider whether lifestyle really helps with glaucoma. But the first thing I think about is, are you telling somebody something which is likely to be healthy for them or could be unhealthy for them? I would really stick with things that are likely to be healthy for them. You really want to consider things in terms of risk. If somebody is like got a low genetic risk or just has a low glaucoma risk, that they have early disease, they're on one medicine and their pressure is 8. I don't think this is the person that needs a MIGS, and I don't think that this is a person who really needs like a lifestyle change. I think they're going to be fine. So you really want to do it in kind of these people who have borderline cases and you're not really sure whether you've controlled them or not. And I think in terms of the research, it would be really fun to start looking at behavior and lifestyle in conjunction with genetic risk. And I think we're going to learn a lot more that way.